and avoiding wrong lens implant errors. So coming to the how to identify the cause, first the formal subjective refraction is very important. Thorough dilated examination to identify the surgical cause, like look for tight corneal sutures, placement whether the placement of intraocular lens whether in the sulcus or there is a subluxation of the IOL. Look for a distended capsular bag because of retained viscoelastic. Sometimes it may cause myopic shift. Look for presence of corneal pathology, mainly look for corneal edema or corneal scar that may even influence the refractive outcome. In the end, even in the retina, you should look for a postoperative cystoid macular edema that also can cause hyperopic shift. So, now you review the refractive history as well as the biometry, the IOL selection process and surgical record. Look for wrong patient biometry, transcription error, selecting a lens from the sometimes from the ACOL column, or incorrect A constant, or also you should look for the incorrect formula in particular case. Look for, check the axial length by repeating the biometry, check for abnormal keratometry. Sometimes what happens, the presence of high case or astigmatism, sometimes you might have missed the underdiagnosed keratoconus. If there is no error there, then you can contribute the refractive surprise attributed to the effective lens position, and you can expect the similar kind of error in the fellow eye also. So coming to the clinical management of refractive surprise, explain the error openly and offer an apology. But this is not a declaration of the guilt, but an acknowledgement that you are not achieved the desired target refraction. What I do in my practice, I take a second opinion that itself give a lot of confidence to the patient, even for us also. So what are the options? It's available whenever there is a refractive surprise. Doing nothing is also a good option, because most of this refractive surprise do not require a further surgery at all. Because if you left behind some amount of low myopia, always it gives a good monovision and patient can ability to read very well unaided. And most of the patient might have been there already using the glasses, they don't mind wearing the glasses later on. Always the benefits and risk of further intervention should be also very much explained. So coming to the management, correcting this surprise depending upon the first comfort of the surgeon, which intraocular lens used, and how long been the lens has been implanted. Of course, those who are having a retained viscoelastic, of course I do early capsulotomy that disperse the visco behind, then allow the anteriorly displaced intraocular lens to move posteriorly. Coming to the other option is corneal refractive surgery, but in my case I normally wait till 3 months. For small amounts of residual liver, the results, I think there are two options are there, either you can go with PRK or with the LASIK. For older patient, I prefer to do PRK because there is already they might be having some amount of dry eye problems with them. For younger patients, I prefer to do femtolasic. So coming to the what should be the ablation profile, most of cases we do with the wavefront guided treatment. So most of the studies down here shows that results with the wavefront guided treatments are much better than the topo guided treatment. So of course, LASIK will be always a safer option, because if you have done already YAG capsulotomy, because you cannot do the IOL exchange once already YAG capsulotomy might have done. And also you can do like, you can adjust the treatment if you can make the flap in LASIK. So what are the limitations for laser vision correction, especially if you left behind high refractive error, low corneal stromal thickness, and a limited availability of excimer laser in most of the surgeons? Of course, you have to spend extra cost. Now, other options are there, I think, IOL exchange or piggyback lenses. Especially IOL exchange is useful in effective in reducing the high degree of spherical error. The greatest advantage, it do not alter the anterior corneal surface and do not change the corneal refractive power also, and you don't require the special sitting like in the refractive surgery. So add-on or this one piggyback lenses, Dr. Ramurthy sir was showing in his one of his video about the piggyback lenses. Most of these lenses also works out very well, because as this corrects the manufactured refractive error, you need not have to know the original intraocular lens power, which is not required, and piggyback lenses are less accurate than the laser refractive surgery, but good for higher degree of refractive error. Avoid always risk of IOL exchange as well as those with the ocular surface wherever laser is not suitable. So piggyback lens is the easiest surgery. The only disadvantage why I heard some of the patients, they may come up with the pigment dispenser syndrome. So I'll just conclude because of my time is up. So laser vision correction has been shown to be viable, non-invasive and accurate procedure to correct diametropy after cataract extraction with intraocular lens implantation. Lens-based procedure, IOL exchange or piggyback lens implantation are also possible alternatives. Piggyback IOLs technically easier and more accurate than IOL exchange. Better indicated in case with extreme emmetropia, corneal abnormalities or when there is no available excimer laser platform required. I will not be showing my videos. Thank you again the whole scientific committee for this opportunity.
Thank you, sir, for a very informative talk. Any quick questions from sir? Anything from the audience?
I think, when would you resort to a IOL exchange?
So whenever a high degree of refractive error, especially those are like left behind around more than -4, normally I look for a IOL exchange. Again, depending upon what was the problem happened during the surgery, I need to look for exact how much is the pupil dilatation also. If pupil is not dilating that much, still my option will be last.
No, I quite agree with you, especially if you experience inappropriate power, immediate post-operative period, maybe an IOL exchange is a good idea.
Yes, sir.
But if the patient comes to you months later with a fused capsule, not only is a question of explanting the lens, but you do not know what is the exact power of the lens that should go in. Why exactly you face the problem. So putting in a piggyback lens where it's just based on the residual power is an easier option, especially if the amount of power variation is a little higher.
Yes, sir. I even tried with the piggyback lenses, sir. Results are very good. Only thing is that these lenses are a bit expensive.
Oh, you get the Indian versions now, which
Yeah.
are reasonably cost effective.
Cost
The
effective.
Sulcoflex lenses are quite expensive.
Very expensive,
And
especially
they
from
are,
Rainer.
You have to wait for them, especially if there's a toric component. But the Indian lenses are more reasonable.
Yeah, I tried in couple of cases. I was seeing your videos, but the gap between these two lenses, sometimes you may have some kind of layer in between. Sometimes it may disturb the vision.
Yeah, that was a problem which was experienced when, the early the piggyback lenses, both the lenses were put inside the back. And there used to be a interlenticular opacification that was called the red rock syndrome. Now that primary lens is in the capsular bag and the secondary lens goes in the sulcus, it's the overall diameter of 14 millimeters, this problem is not there.
Yes. Thank you so much.
Thank you.